I am so excited about this episode because we have so many amazing OBGYN practices, and this is going to change how OBGYN billing is done. So if you guys have ever had that feeling where obstetrics basically is reimbursed in this obscure way that really never fully captures all the work that OBGYNs do, right? The late night calls, the high risk counseling, the extra prenatal visits, the complex, psychosocial care, the detailed chart reviews, really the hours spent on managing a 9-month pregnancy or any complications. And yet all of it is basically forced into this global payment that barely reflects the complexity of modern maternity care. Well, that model is actually getting ready to be blown up. And it is all getting ready to change in January of 2027. And we don't know all the rules yet. So today I'm going to talk about what we do know. But we do know that for some practices, this change is actually going to be good news. And when I brought this to our OBGYN team, one of them actually commented that we have a practice that is already, helping to pave the way and coding in a way that makes sense to basically communicate the complexity of their patients' situations that are going on. So today we're going to walk through what's happening, why it's happening, what we know so far, what we don't know, and basically what your practice can do to prepare. So this episode is going to be a game changer for OBGYN practices across the country. As you guys know, I'm Dr. Heather Signorelli, and this is the NotRevMD podcast where we help do medical billing for private practices. And we love OBGYN practices. This is a subspecialty knowledge that our team has. I really think we have some of the best OBGYN billers out there. They're extremely knowledgeable, OB subspecialty certified from a coding perspective, and just incredible humans as well. So let's start with the big question. Why is there a change going on right now with regards to obstetric billing? According to ACOG, the global obstetric codes are basically no longer reflecting the standard of care that physicians provide today. And really, any of the physicians who provide this care today could tell you that. So we all know that payment for obstetric services, when global codes were created, it was decades ago. Prenatal care looked very different. We didn't have routine depression screening. We didn't have the same social determinants of health. We didn't have the same level of genetic counseling, vaccine counseling, nutrition counseling. Just all of the monitoring that goes on has just changed from decades ago. And so all of these components have become standard expectations. And also women are having care later in age. And so that also changes the complexity of a pregnancy. And so the payment structure never changed and it hasn't evolved. And so now it's time for that to evolve. We just don't exactly know what this is going to mean from a reimbursement perspective. My hope and my optimism is that it's going to mean practices who are caring for higher risk patients, who do have more socially complex patients, who do need more support, will be given a higher reimbursement. But I think that's yet to be seen. The global payment really rewarded simplicity, right? It didn't reward complexity or complications with regards to a 9-month term. And so I do think that practices have felt financially squeezed. And we have some practices in certain locations whose global payments are astonishingly low for 9 months of care. And of course, that's not because they aren't working hard and that they're not, obviously providing exceptional care, but it's just that the model just really doesn't reflect reality. And so we are starting to see several state Medicaid programs like Mississippi that stopped paying global maternity codes years ago because the model made it too difficult to tell what care was actually provided. And it created payment inaccuracies and major conflicts when patients switched providers mid-pregnancy. So today's move to unbundle maternity care isn't just an administrative change. It could be a really good change if done correctly. Again, I'm optimistic here, but there's still a lot that we don't know. But essentially, I think the idea here is that it's trying to recognize obstetric care that is far more dynamic. It is complex. It is individualized, more than just a single code can capture, especially for 9 months of care. And for practices who do a lot of high risk or complex care in pregnancy, this may actually finally align payment with the level of work that they're performing. So let's now talk about what's officially happening or what we know so far, right? So January 1st, 2027, basically global obstetric billing model basically disappears. So 16 codes are going to be deleted. Those include the big ones, right? The 59400, 59510, 59610, 59618, the antepartum packages, and postpartum only codes. Now, 6 existing codes, like external cephalic version and fetal monitoring, are being revised. And then there's going to be 12 new maternity codes that are going to be introduced. Right now, they only exist as basically like placeholder numbers, so I'm not even going to rattle those off. But the final code descriptors are still being worked on, and so we don't have details on those yet. But here's what we do know. So these new codes will basically break prenatal delivery and postpartum care into separate parts. So instead of it bundling all together, there's going to be prenatal, delivery, and postpartum. No more single bundles, no more one size fits all. ACOG is already recommending that Medicaid and commercial payers obviously fully utilize E&M codes, which are those 99202s through the 99499 range for prenatal and postpartum visits. And they are also recommending using modifiers TH to distinguish maternity-related visits. But this is a huge shift because rather than being paid one flat fee for the entire pregnancy, regardless of the number of visits and complexity or the level of risk, physicians are now able to bill based on the actual care provided. So if you deliver more complex care, you can code for more complex care. Now, if you spend more time managing high-risk conditions, that work is also intended to be captured through this process. If you provide telehealth support, nutritional counseling, or just coordinating care for social services, we're hoping that all of those are going to be recognized in a different way. And so for many practices who do have more complex patients, this obviously is a significant opportunity. Now, let's walk through what we currently know. And we know that services basically provided at or near time of delivery will be separately billable. They won't be swallowed up in this global package anymore. We also know that labor management that occurs on a different calendar day than delivery or in another facility on the same day should be billed using inpatient E&M codes. So this is, some of the nuances that are starting to come out. Again, final code and releases have not come out. This is just, what we're getting from ACOG and AAPC so far. So this means that prolonged labor or multi-day management can finally be reimbursed appropriately, which is great news. We also know that multi-gestational deliveries, right? So twins, triplets, yada, yada, will be billed with multiple units of delivery only codes using some modifiers for the second and subsequent deliveries. So again, positive step for practices. It'll be curious to see how reimbursement is created for some of these new codes and really just how this is all going to add up over a 9-month period. Again, I'm optimistically thinking that hopefully this increases reimbursement for our OB practices. I think many of you guys know, maybe I've talked about my dad. He was an OBGYN, ran his own practice for 30 years. He was a solo practitioner. And so I, just think back, obviously he practiced for a long time. He's now since retired, but what OB pay looked like back then versus what it looks like now was very different, right? And I think our OB docs deserve more. So we know that many states are already, operating under this unbundled prenatal care requirements. And we have practices that are already billing antepartum visits individually, and it is working. So we're just excited to see this again. Optimistic here. All right. So I know I talk about this a lot, but what we know that's going to be really important is documentation. And I talk about this no matter what type of practice that you're in, but it is going to be even more important to start documenting completely about what you're doing for your patients, because you're going to want to prepare for the change that's coming in 2027. So if you aren't already documenting thoroughly at every single visit when it comes to your prenatal, pregnancy care, deliveries, all of the things, postpartum care, you're going to want to do that even more when this change goes into place, because every visit is going to need to stand on its own. And we know that you're going to have very transparent, clear notes to align with the level of complexity that you're billing so that you can get recognized for the level of work. Now, let's talk a little bit about what we don't know. Of course, there are going to be some important details we don't have, right? We don't have the final definitions of the new maternity codes, what counts as certain type of visit, how postpartum care is going to be broken down, what each code encompasses. We don't have our views yet. We don't know exactly how really each service is going to be valued by Medicare. And by our commercial payers, of course. So lots to come through in terms of changes. Now, we may see some commercial payers who move quickly, others may lag behind. So we're going to have probably some practices that have dual workflows depending on the payers. We just don't know what and how long that's going to look like. We don't know what those documentation standards are going to look like for all of those codes. Obviously, for some of the codes like the E&Ms and so forth that are going to be plugged into other areas within the pregnancy period, we do know those. So it's going to be interesting. I think the other piece that we don't know is frequency limitations and medical necessity thresholds for certain prenatal or postpartum visits. Like, what is that going to look like? Ultrasounds, so forth. But none of these unknowns should make you worry, right? Because at the end of the day, changes happen all the time. When the changes come and we get the details, we'll be able to prepare. Sit down with your team, recognize, how you're billing today. Maybe you're doing some of this type of billing already, which is great. Documentation, again, is one of the major things that you can make sure that you and your team are doing today and being prepared for the next time. And obviously, all new changes are going to take time to get used to, but I think that's why having open conversations with your billing team and understand that as these changes get put out there, right, you and your team and your billing team are prepared and will have hopefully a stronger financial position. At least that's my hope. Now, these changes could increase revenue, which is my hope, because for many OB practices, right, if you're caring for patients with hypertension or diabetes or obesity, depression, then those complications, those patients are going to typically require more care, right? There are more visits, more counseling. And so under the global period, right, those things kind of get rolled up. But under this unbundled model, every medically necessary touch point can be recognized. And again, some practices are already billing additional E&M visits to match the complexity of their patients. So I do think some of this is already going on and getting paid. And so talk to your team about what that looks like if you aren't doing that today or just evaluating. I would say, some of the ACOG conferences are already starting to talk about this. And I've seen information on their website about, watching for details and information around this. So more frequent prenatal visits and higher level E&M visits when complexity increases, again, that can all lead to increased revenue. So I think that the hope is that this new model reimburses appropriately for these higher risk patients. And again, I do think some of this is already starting to shift in anticipation of the 2027 changes. Now, I definitely don't ever recommend upcoding or doing something that's not per the code. And that's why it's really, really important to talk to, coders, OBGYN certified coders around this. One of the things I've learned in running a billing company is OBGYN, in my opinion, is one of the hardest billing areas I think I've ever seen. And we have many different types of subspecialties. I think second is maybe allergy or rheumatology, but that's just because there's all the J codes and everything. But I could be over complicating things. But OB is definitely hard. And so I think having OB certified coders who are part of your team are absolutely critical. So if you are looking at your team and wondering if you have the best knowledge when it comes to medical billing, reach on out to us. We'd love to meet with you and your team and just share more about us and how we have a special niche when it comes to OBGYN billing. So excited for what is really a first time change in a really, really long time and moving in a direction that allows practices to get reimbursed for the care and the complexity of their patients. So what can you do today? Obviously, like I said, strengthen your documentation, make sure that you really, really understand what it takes to document certain visits. And I think, watching for updates, we'll be continuing to provide updates as these come out. And next is really making sure that your billing in general is steady, right? Because when changes come, you want to make sure that you have time to focus on those and that you're not worried about patient AR, insurance AR, and all of these other different things that impact your revenue cycle, right? You can focus on the new changes. And so if you are struggling with, following your metrics, setting KPIs, get those done now so that you can focus on these changes as they come out. Obviously, always great to have templates for your physicians to capture, all of the different, areas within a patient's visit, medical decision-making, counseling time, all of those without adding burden to them. Make sure that your front desk team is prepared for visit by visit billing, right? That's going to be a big thing. Obviously, eligibility checks should be done no matter what, every single visit, even if it's bundled today, because those insurance updates and benefit verifications do impact billing at the end. And so if there is a change mid-pregnancy, you want to know, you want to be able to bill for it appropriately, because there are a lot of nuances, as you guys know, about billing for pregnancy, even today when there's a change of insurance based on the number of visits that were done in each of the carriers. And last, of course, look at your payer contracts. Once those RVUs are released and once those new codes, you're going to want to understand exactly how different payers are going to value this care under the new model. And so really, really important to just stay on top of this. Again, we'll be sending out communication. So if you haven't already subscribed, head on over to NatRevMD and subscribe to our newsletter, and continue to watch for updates. And as always, if you are looking for a new billing partner, head on over to NatRevMD. We would love to help you out, and hope you guys have enjoyed this exciting news, I hope, and we'll continue to keep watching for updates. All right, thanks so much.